So we're going to continue on with our grand rounds, and we're very lucky today to have Frank Miller, who's come here from Northwestern to speak to us. Frank did a 6-year undergraduate and MD degree at Northwestern, and then did residency there, and then spent a year at MGH, where he did his fellowship, and eventually headed back to Chicago, and has never left since, basically. He is currently the director of the body imaging section there. He's also the medical director of MR imaging. He's also the chief of GI radiology, and he is an endowed professor. He's the Lee Rogers Professor of Medical Education at Northwestern. He's very prolific, has published over 170 peer-reviewed articles, and has a main interest in abdominal and pelvic MR imaging. So we are really lucky to have him come here today, and he's going to speak to us about assessing response after hepatic interventional oncology. This is a topic that's very near and dear to many people in this department. So thank you, Frank.
Thank you. Thank you for the wonderful introduction. Great job on the resident presentation. I'm going to be talking, as mentioned, about assessing therapy response. I'm going to discuss the imaging of liver-directed therapy. I'm going to focus on RF ablation, transarterial chemoembolization, transarterial Y90 radioembolization. I'm going to try and talk about some of the unique imaging interpretation related to liver-directed therapy, limitations of some of the size criteria. And this is something we certainly at Northwestern had to learn, because during my residency training and fellowship training, it wasn't something that was very actively done. And certainly with people like Dr. Geschwin and by me, Riyad Salem and Bob Lewandowski, it was one of those things that you don't want to say they were a failure of response when you learn that they actually get an outstanding response a lot of times. So I'm going to discuss the limitations of the size criteria, but I'm also going to talk about newer techniques, a little bit about diffusion-weighted MRI, which can be helpful. And this is an example of one of those challenges. So this is a patient who clearly has a large HCC and some additional lesions as well. And this is what happened after Riyad had treated the patient with yttrium. So at this point, I'm saying to myself, were you in the lesion? Did you target the lesion? What exactly happened? But quickly you learn that this is not unusual, because without any therapy, this is 3 months later. This is 1 year later. This is 16 months later without any therapy. So clearly the patient had an outstanding response. Most institutions, other than here or somewhere else, the patient would have been dead by now, but clearly 22 months had an outstanding response. So it's clear that our assessment of therapy needs some work. And these are, as you know, among the most difficult interpretations in radiology. Certainly no one fights to read these cases. In the old days when we had requisitions, the requisition would just sit there. Or if you have PACs and you have eyeballs on the exams, you typically won't see an eyeball on there unless a resident or a fellow mistakenly maybe opened the study or something like that. But my hope is that you'll feel comfortable reading them as well, because they're actually challenging and also potentially, in my opinion, interesting to read. It's important to recognize that there's no significant decrease in size of the lesion sometimes, or paradoxically, there could certainly be an increase in size, especially when you're dealing with ablative therapies, as well as with embolization. And that's felt most likely to be due to hemorrhage and necrosis. There's certainly no uniform standard of interpretation, whether within an institution or across institutions. There's different ways of interpreting these. In addition, ring enhancement can be mistaken for tumor, and it's actually a sign of a good response with post-treatment changes, including scar tissue or reactive edema. Our anatomic imaging biomarkers look at traditionally chemotherapeutic agents, look at cytotoxicity, and they eliminate the neoplastic cells. As a result, classically, we're taught to look at the change in the tumor size, and we look for disappearance of the lesions. And this is really the only widely accepted and validated marker of treatment response in the past. And unfortunately, as you guys know, it doesn't apply for local therapy of HCCs, because generally the tumors don't disappear unless over a period of time. To get a sense of the problem, HCC is the 5th most common cancer worldwide. It leads to about 500,000 deaths per year. and hepatitis C is the most common risk factor with patients with hepatitis and cirrhosis. 1 to 8% develop HCC, and this incidence has doubled over the past 3 decades, and it's projected to increase despite new therapies. And another problem is those with HCC are waiting a transplant certainly surpassed the supply of cadaveric organs, so it becomes more and more important to have additional therapies available. Early experience using transplantation was dismal due to poor patient selection. The recurrence rate was 60 to 70% within 2 years. And this I found interesting that the 1-year survival was only 25 to 35%. Initially, the Department of Health and Human Services had deemed HCC a contraindication to transplantation. As you know, the criteria for transplantation are based on the Milan Criteria, based on pre-transplant imaging, patients that don't have extrahepatic spread, and the 4-year survival has been good, 74%, with a recurrence rate of less than 10%. And this has been validated in numerous studies with over 1,000 patients with excellent survival. And looking at it, it would be 1 lesion less than 5 centimeters and 3 lesions, none of which are over 3 centimeters. Unfortunately, the vast majority of hepatocellular carcinoma patients are not candidates for orthotopic transplantation because they're either outside the Milan criteria, they may have larger lesions or too many lesions, they may have portal vein thrombosis, or they may have metastatic disease, which is a relative contraindication for other therapies. In addition, prior systemic chemotherapies, unlike other diseases, although they're getting better, they haven't shown significant survival benefit. It's usually on the order of several months, but certainly not years or cure. And the tumor may progress while the patients await transplantation, causing the patients to no longer meet the criteria. So some of the treatment options currently are methods to bridge or downstage patients for transplantation. We're doing a lot more of this at Northwestern, where patients are getting downstage and then they can have a transplantation. And some of the different treatment options are certainly more than these, but the most common ones, certainly ablation methods, transarterial chemoembolization, whether you're using traditional or drug-eluting beads, yttrium, or forms of combination therapy. So as an oversimplification, radiofrequency ablation works because it destroys the tumor by heating. Generally, you treat when there's 3 or fewer lesions and they're less than 3 to 4 centimeters in long axis to make sure you have a complete ablation. And percutaneous RF ablation has certainly emerged as a definitive therapy for those with small HCCs, with results reported which are similar to surgery for patients that have HCCs less than 5 centimeters, 96, 82, 71, and 68%, ranging from 1, 2, 3, and 4 years. I think imaging the patients after ablation sometimes can be challenging, certainly. We tend to image them immediately after the procedure, then at 1 month and 3 months, and then 3-month intervals progressing over that time. And what you look for is you look for immediate non-enhancement, and if you're doing MR, you would look for hypointensity on T2. Generally, what you want to see is you want to see a sharp interface, and you want the margin to be over 5 millimeters because you want to make sure that the zone of treatment is larger than the lesion itself. And then you look for the lesion to involute over a period of months. Similar to other therapies, as I'll talk about, ring-like enhancement is normal. It's felt to be due to benign periablational enhancement at the treatment margin, but it can mimic tumor. So here's an example of patient pre-treatment. You can see that this lesion is here. And following treatment, you can see that the lesion's certainly larger, but notice that it's no longer enhancing, it's necrotic, and that's what you want to see. And it's only later that the ring of enhancement goes away, but notice by 4 months later, the lesion is certainly smaller, suggesting an excellent response. And again, there may be a little bit of enhancement along its periphery, but it tends not to be nodular enhancing. Follow-up imaging, I think, can be difficult because the residual or recurrent disease is often at the periphery of the ablated lesion. It often enhances, and it may relate to lower energy deposition and reduced heating. Here's an example of a patient who was treated, but you see this nodule of enhancement on a follow-up imaging, and it behaves similar to the primary tumor. It's washing out, and you see capsular enhancement, as you would suspect in a tumor. And you can also see in this particular case, it showed restricted diffusion, so it was bright on diffusion-weighted imaging. Here's another patient. This is the venous phase where we have a HCC where it's washed out. And I'm showing coronal images because in this particular case, it was helpful to see the abnormality on the coronal images. But after ablation, it looked like initially there was probably a good response. This is 2 months later. This is 4 months later, and we're starting to see some heterogeneity here. but it clearly shows by 7 months that there was a recurrence along the periphery, but in this case along the superior margin due to recurrent HCC. For chemoembolization, the principle is that the normal liver has a hepatic arterial and a portal venous blood supply, predominantly supplied by the portal vein. In contrast, tumors, especially HCC, are almost completely supplied by the hepatic artery. So the interventional radiologists treat these by directly injecting the hepatic artery with either embolic material, chemotherapy, or radioembolization. This actually was obtained during what we call the TRIP MRI, where we had one unit where there was an MR and there was an interventional suite. And Reed Omri, when he was with us, he would do an injection as part of an NIH grant. And you can see this is only 5 cc's of GAD, which was diluted. So it basically was 1 cc of GAD injected into the artery. Following therapy, you could see nicely with the chemoembolization that the tumor was obstructed, ischemic, and no longer enhancing. So this was immediately done after procedure, but nicely illustrates the usual enhancement of the tumor, arterially enhancing and washing out, and following therapy, no longer enhancing. There are various modalities that you can use certainly for follow-up, whether it's CT or MRI. In general, for imaging, if we do chemoembolization, we'll image immediately after procedure, generally using CT to look for the lipidol accumulation within the treated areas. And then we image every 4 to 6 weeks, and then at 3 to 6 months. With radioembolization, we typically image at 1 month and then every 3 to 6 months. And what are we looking for? Well, we certainly look at the traditional features. That would be the decrease in tumor size, and that would include either WHO or RECIST or volumetric measurements. But we also want to focus, as I'll talk about, on necrosis, which is defined as the lack of enhancement of the lesion. And there's different criteria, EASL and MRECIST. But now there's also other criteria, things that we can look at, whether it's functional, changes at diffusion, perfusion, metabolic activity at PET scan, or serum tumor reduction, amongst other things. And as I mentioned before, different institutions certainly report the findings differently, which can affect transplant and treatment assessment. A lot of times we'll measure the size of the lesion, including the necrotic part, but I think it's become more and more evident and more important to start measuring the enhancing part, because that's basically the tumor that we're looking at. And sometimes it's hard to measure because it's not always a focal nodule of enhancement. In addition, the type of treatment and the imaging studies certainly vary, and they should depend on the local expertise of your institution. Proponents of doing volumetric measurements of tumor response certainly describe that most tumors aren't spherical, and volumetric measurements may be more accurate, especially when you're looking at irregular shaped or confluent lesions. But the RECIST working group hasn't included volumetric measurements due to lack of clinical data and limited availability of technology. In addition, as we all know, volumetric measurements require volumetric software, which can be somewhat time-consuming, especially if you're in busy clinical practices, as we have here. Semi-automated and automated measurements, certainly by commercial software, is improving and hopefully will continue to improve. But I think similar to volume rendering and 3D rendering, a lot of radiologists don't like to do it unless it's easily incorporated into our PACS system. And here's an example of a volumetric image where you can see it's certainly grown on the regular image, and then you can get nice images like this that Dr. Yagmai lent me, where you can see the lesion's certainly bigger on volumetric. Here's an example where if you just looked at the axial images, and this is a little more unusual, they measured the same size on the axial images, but when you looked at the volumetric measurements, the right lesion was smaller and the left lesion was larger, but this obviously is not the common situation. Here's an example using chemoembolization where you see the lesion on the pre-therapy, then we do the post-therapy. We assess for the lipidol accumulation. You can see it accumulating within the lesion, suggesting that the lesion was appropriately targeted. And then on the MR scan, you can see that it was bright on the pre-contrast. Sometimes it's hard to tell if it's enhancing. You could certainly put ROIs on it, but if the patient breathes similarly, it's certainly helpful to do subtraction where you do the post-contrast minus the pre-contrast. In this case, you could see beautiful response where there's no longer enhancement with the exception of the rim of enhancement, which is normal. This was a 71-year-old female, has an HCC. It was treated with chemoembolization. You could see the thiodol accumulating. Good response 1 month later, certainly getting smaller 6 months later. 10 months, we see this little nodule of enhancement, which at 25 months grew. You can see it on the subtraction as well. So this was a recurrent hepatoma. This was treated with an excellent response. Sometimes when you use the thiodol or Lipiodol, I should say, we use it to assess targeting, and you can see sometimes it persists and it's retained. Sometimes it can obscure the tumor. In this particular case, it was helpful to have the MRI because you could see the enhancement pre-treatment, and then following treatment, it no longer enhanced, consistent with an excellent response. And it's certainly smaller as well. This is an example of HCC. Usually we don't do a PET scan, but this one illustrates, even though the size is the same, certainly with necrosis, you can see it's no longer enhancing, consistent with an excellent response. Sometimes the PET scan is a lot more clear, not in this particular case because I think it's clear, but it nicely illustrates the presence of PET uptake here. Following therapy, no longer any PET uptake, so it increases your confidence level as well. Sometimes tumor marker reduction is helpful to look at. Here's an example of a patient with a tumor with an AFP of 850. Notice after therapy, it looked very similar, but notice the AFP certainly has dropped down to 80, and no further therapy was done. By now, it dropped down to 4, so we can see there's been an excellent response. Next, I want to talk about transarterial radioembolization or yttrium microspheres. This is local radiation therapy for unresectable tumors. The mechanism is that tumors are more vascular than the normal liver. As I mentioned before, they're supplied by the hepatic artery, and the yttrium is trapped in the capillaries, resulting in over 3-fold exposure of the tumor relative to normal liver, and allows the tumors to receive over 150 gray. This is a schematic showing what they look like. And you can see here, this is a patient who was treated, had about a 3-centimeter lesion. Certainly after therapy, it's larger. Now it's 7.5 by 4.6 centimeters, but you can see it's now necrotic, consistent with an excellent response. Another example, pre-treatment, you can see the hepatoma. Post-treatment, you can see that it's clearly necrotic. This one I thought was interesting because we have path confirmation. See the dead tumor here. You can see the normal liver, which has an area of necrosis because of the therapy, but you can see that the whole tumor was completely necrotic compared to live tumor. Sorry. This was a recent case that we had done, and we usually don't routinely use Eovis, but this one I thought was interesting. You could see this was a patient with colon cancer, had a metastatic lesion here, certainly has PET activity, but we gave the Eovis, and what was interesting about this, it shows the normal liver function. It also shows as opposed to external beam radiation, where you get a lot of effects on the remainder of the liver, it shows predominantly the liver affected and a small portion of the adjacent liver affected as well. This is just to show that even with portal vein tumor thrombus, you can see with the therapy, in this case with yttrium, pre-treatment, you can see the tumor thrombus as well as the tumor. Whenever you see tumor thrombus, you want to look for the tumor. In this case, you can see the tumor has clearly gotten smaller. At this point, you might think it's still enhancing, but no further therapy, smaller at 3 months, and this is 26 months, consistent with an excellent response despite the tumor thrombus. So this was one of our early studies, and the reason we got involved in this, as I mentioned, it was something new to me, and I really wanted to figure out what was going on. This was dating back to 2007. We looked at 42 patients, 52 lobes, 76 treated HCCs, and at the time we weren't sure how to assess therapy, but we looked at WHO and RECIST, and we looked at necrosis, and we sort of made up these numbers of 100% necrosis being complete response, over 30% being partial, and stable disease. But what was interesting, we maintained the progressive disease, meaning that if it grew in size, or if there were new lesions, we called it progressive disease. But as you know, the natural history of these tumors are to get new lesions, and the increase in size could be a result of therapy. But I thought it was interesting because when we looked at the size criteria, only about a quarter responded. But when we had necrosis or combined criteria, over half of them responded. And again, I think this is certainly much higher because we included progressive disease as a growth in the lesions or new lesions. And here's some examples. So here's a patient with a HCC, a CT scan. You can see a month later. Certainly the size didn't change, but you can see that there's this nodule of enhancement, which we'll talk about, but over time it's getting smaller, so this was considered a partial response. Similarly, here's a patient who pre-transplant, we were bridging the patient to transplantation. You can see the HCC At 1 month later, you could still see that nodule of enhancement, but the patient ended up having a transplant, so we had the explant to look at, and at the time of the explant, it was completely necrotic. The whole tumor was dead, despite the nodule of enhancement, which I thought was interesting. In addition, here's an example similar to the other ones. Pre-treatment, you see the lesion. Post-treatment, there's no enhancement. And again, at the time of explant, normal dead liver, I should say, normal liver on this side and a small area of adjacent fibrotic liver as a result of therapy. So this nodule of enhancement we felt was maybe due to residual enhancing tumor or slowly treated tumor. And over time, a lot of times these turn out to be slower treated tumor or post-treatment changes because it often doesn't metastasize or grow with the atrium. And it's different from RF ablation or chemoembolization. So if we see a nodule of enhancement following chemoembolization, it looks focal, or RF ablation, we're certainly worried about tumor. With atrium, we're not always sure, and you don't always have to treat them as early. Another example, HCC, pretreatment, post-treatment, again, you see it's predominantly necrotic, but again, we see that nodule of enhancement on the 6-week post-treatment image. No further therapy was administered, but you can clearly see by 3 years that that was probably slower responding tumor or enhancement because of scar tissue or something. But at 3 years, it's gone. Interestingly, when we looked at our study initially, what we found was that if you look at size criteria, you have to wait 120 days to see a response. So that was certainly way too long. If we look at necrosis, it's reasonable. It's about 30 days, so it's a lot earlier. So you can assess the response of therapy, and this is helpful, especially if the interventional radiologists are considering treating another lobe or another lesions. In addition, there was no correlation between the response and the initial size of the tumor, whether it was 6 millimeters or was 19 centimeters, and there was no correlation whether there was tumor thrombus or what the AFP was. This thin rim of enhancement that I mentioned before was seen in about a third of our patients, measured less than 5 millimeters. 84% of those with this thin rim of enhancement responded to therapy, and it was compatible with inflammatory reaction, and it correlated well with histologic necrosis. So here's an example 1 month later. Here's another example, pre-treatment. 1 month later, you see that rim of enhancement. You still see it at 3 months. You see it a little bit of at 6 months, but clearly the tumor is no longer enhancing. It's getting smaller, and by 9 months, you no longer see it or very little of it. We also looked at metastases, because the reason we looked at metastases separate, because we did a lot of PET scans in these particular patients. We looked at 122 metastatic lesions, compared our results with PET scans. And again, similar results with the WHO and RECIST, about a quarter responded. If you had a necrosis and combined criteria, about half of them responded. But again, I think this is an underestimation because we're looking at progressive disease as new lesions or growth in lesions, which again, isn't necessarily progressive disease. Interestingly, when you looked at our combined criteria and you compared it to PET, clearly PET performed the best. 63% responded based on PET scans. As mentioned before, the liver metastases and increase in size can be seen in responding lesions, but certainly PET showed an earlier response. Unfortunately, PET missed a few lesions, some of the smaller lesions. Interestingly also, we had said that if the index lesion responded, the new lesions represented a failure of treatment, but in many of these cases, they could be retreated, and they weren't necessarily a failure of retreatment. Here's some examples. If you look at the CT scan, it's certainly smaller. Sometimes it's hard, though, to tell, is it responding or not? And that's where I think PET is useful, because you can clearly see that there's activity, and then following therapy, we no longer see the activity. So that's consistent with an excellent response. Similarly here's multiple lesions, pre-treatment, post-treatment. Very hard to tell. You may say it's a little bit lower in density on the post-treatment, but it's hard to tell. But I think once you have the PET scan, you can clearly see it goes from having activity to no longer having activity in the treated lesions, consistent with an excellent response. Sometimes the interpretation can be challenging because you get all these perilesional changes where you get this hyperemia around the lesion, and it could be due to inflammation, edema, or hemorrhage, but this usually resolves over time, so if you look and follow up 3 to 6 months later, it's usually gone, and you shouldn't mistake this for tumor. It's also important to recognize that with yttrium, especially with metastatic disease, sometimes you can get what's called yttrium-induced cholecystitis, where you actually see a hole in the gallbladder, which we don't see a lot of times with acute cholecystitis, but you initially we used to worry about this, but in reality, a lot of these patients don't require surgery. And you can see nicely the yttrium within the gallbladder wall. Just to show that the first case wasn't the only case where you see a good response, but it's hard to tell with the anatomic. Here's another example where the anatomic lags functional changes. So here's somebody pre-treatment, post-treatment 1 month later. Really hard to tell that there's been a response. Even at 3 months, you might argue it's a little bit more necrotic, but I think it's really hard to tell if there's been a response. No further therapy was administered. Here's 6 months, certainly getting smaller, 10 months, 15 months. So by 15 months, certainly predominantly necrotic. But this brings me to the next topic that I want to talk about, and that's the use of diffusion-weighted imaging. So when we look at enhancement, what are we looking at? We're looking at the extracellular space. We're certainly looking at tumor vascularity. We're looking at enhancement of the lesion. In contrast with diffusion, we're looking at altered water mobility. We're looking at cellularity and the integrity of the cell membrane. So here's an example of an HCC with restricted diffusion. Not all HCCs do have restricted diffusion, but I'll talk about that. But you can see, as I mentioned before, I think it's difficult to assess therapy sometimes, but I think diffusion can have a role in these particular patients. What are the advantages of diffusion? Certainly that it doesn't require contrast material. It's especially helpful in patients that we see often with renal dysfunction and you're concerned about NSF, or they're allergic to gadolinium and you want to avoid giving gadolinium. It's relatively quick to perform, taking only an additional few minutes. It provides function information in addition to anatomic information. So diffusion looks at random Brownian motion. Tumors have restricted diffusion as illustrated here, and then when the tumor is treated, you end up with free diffusion, you get some more free water. This is from an AJR article where you can see there's high cellular density and intact cell membranes due to viable tumor. Following treatment, whether you're dealing with solid tumors, generally what you end up with is defective cellular membranes, so you get, similar to necrotic tumors or cystic angiomas, you end up with a lot of free water. So an oversimplification is that following therapy, tumors that have restricted diffusion, in other words, they're dark on ADC or apparent diffusion coefficient maps, become less restricted diffusion, meaning they become bright on ADC maps and they increase in their ADC value. And some of these changes in ADC precede the changes in size of the lesion. So an oversimplification, bright on diffusion, dark on ADC, live tumor. If it becomes dark on diffusion-weighted images, it's a favorable response. So what we're looking for is we're looking for it to become dark on diffusion and for the ADC values to increase. So here's an example, certainly classic arterially enhancing, washing out with capsular enhancement, bright on diffusion, had therapy, following therapy, again, there's just a thin rim of enhancement, but now it's necrotic, but it's pretty clear when you have it being dark on diffusion compared to before where it was bright on diffusion, consistent with an excellent response. So here's another example. This was a 58-year-old male. You can see that this lesion is enhancing. It went up from 135 units to 195. The numbers don't really matter, but what I want you to focus on, it's about 2.4 centimeters, and the ADC was low, it was about 0.9. It was treated. Following therapy, notice it still is enhancing. So it's going from 130 to 176. The size is maybe a little bit smaller, but the ADC clearly went up. It went up from 0.9 to 2. And it's only at 3 months do we no longer see that the lesion itself is enhancing. The ADC actually went down a little bit, but that's not that important. The key feature is that the diffusion showed a response earlier than the change in enhancement, I thought. Let's look at some other examples. So these are the examples of why no one likes reading these studies. So you can see in this particular case, there's 2 lesions. They're arterially enhancing. They're washing out. But notice that they're both restricting diffusion. Following therapy, the smaller lesion certainly responded, right? It's no longer enhancing. It's necrotic. Hard to tell what's going on with the bigger lesion, right? Certainly probably responded. But I think once you add the diffusion, it becomes pretty evident. No longer has restricted diffusion. Excellent response. Another example, this particular example following therapy, you can see it's got some brightness on the T2, it's got some enhancement following gadolinium. It's hard to tell what's tumor and what's not. I thought this was helpful. Diffusion clearly shows that there's restricted diffusion, similar to the PET scan. So it's analogous to a PET scan. It's showing you the activity, functional activity, viable tumor in this particular patient, probably from a different blood supply. So this is a study, actually Dr. Geschwin was the lead author, and there's a number of studies that his group and Dr. Campbell and others had done while at Hopkins. They looked at 38 patients with HCC. They imaged patients 4 to 6 weeks after therapy, and what they found was that the targeted tumors didn't change significantly in size, but the amount of enhancement decreased like 30% on the arterial phase, 47% on the venous phase, but again, there was less restricted diffusion, so the tumor ADC values increased, and that was an early sign. Similarly, based on their work, and we looked at that as well, and what we found is that the targeted tumors didn't change significantly in size, but the ADC values at 1 month increased, and that preceded a change in tumor size at 3 months. And then this is some of the volumetric work that they had worked on, where patients with cholangiocarcinoma, it's hard to assess, I think, sometimes cholangiocarcinomas following therapy, but what they found was that there was a better response to therapy and it improved overall survival. When you looked at enhancement, it didn't correlate with survival, but if you looked at the percentage volumetric increase in ADC of over 45% and volumetric ADC of over 1.6, it correlated with survival. And this is from their study, where you can see that the size of the lesion was pretty similar, or in fact, it may have grown a little bit. But what you notice is that the ADC shift to the right. So in other words, the ADC values are getting larger, and there's more red, suggesting that there's a higher ADC values. And 92% of the tumor volume had an ADC above this threshold, suggesting an excellent response. Here's an example from our institution. This patient had HCC with sorafenib and yttrium. You could see the enhancement following therapy. It's really hard to assess whether there's been a response. Even just eyeballing it with the ADC, it's hard to tell, but the ADC value went up. And using volumetrics, in this particular case, again, you could see that the histogram shifted to the right, consistent with an excellent response. Another example illustrating why these are so challenging. Here's a patient with therapy. It's hard to tell the enhancing areas, what's tumor, what's not tumor. But I think once you add diffusion to the equation, you can see that there's an area of restricted diffusion due to a tumor. Interestingly, the patient had another lesion, which I thought was better seen on the diffusion. You certainly see it subtly on the post-GAD images, but it wasn't clearly washing out. So in this particular case, I thought the diffusion was quite helpful. Other things that you can look at is something referred to as the primary index lesion. So patients with local regional therapy have at least one dominant lesion, referred to as a primary index lesion, which is targeted during the initial study. And this may be an alternate biomarker for a response in HCC. So the hope is that maybe by looking at this index lesion, certainly would make our life easier if we could just focus on one lesion. You don't have to necessarily follow all the lesions, but only the dominant lesion. And you can measure WHO, RECIST, EASL, and this correlated with disease progression, survival, and Dr. Riaz published this in JAMA. So in conclusion, certainly as I've shown you, I think, and you guys already probably know this, the tumor response assessment is challenging, especially following therapy, whether it's radioembolization, chemoembolization, or RF ablation. Certainly need to evaluate not just traditional size criteria, but also look at necrosis. And then you also have to consider using functional techniques, whether it's diffusion-weighted imaging. I didn't talk much about perfusion imaging because we don't do a lot of that, but certainly perfusion-weighted imaging and PET scans to show a response earlier. And I'd like to thank my colleagues and coworkers. Thank you.